Hi, I'm Susan Taylor with Scripps Health in San Diego, California. Okay, let's face it, us women, we're complicated. Our bodies are very complex and go through all kinds of changes during our lifetime. Some major changes, some subtle changes. From the onset of adolescence, giving birth, through menopause and beyond. Here to talk about the ages and stages of women's health is Dr. Dale Mitchell. He is the chairman of the Department of Obstetrics and Gynecology for Scripps Clinic in La Jolla, California. Thanks so much for being with us.
My pleasure.
If you could laundry list them for us, what are the top 4 stages of women's health?
Well, as obstetricians, gynecologists, we see newborn girls at birth and then we kind of pass them off. Our next exposure is usually late teens, adolescence into mid-20s, what I would consider preconception times. And then
Pre-birth,
we take mothers through their reproductive years, which nowadays, 25 to even early to mid-40s. From mid-40s to 50, the time leading up to menopause, and then from 50 on, after menopause.
So we'll go back and delve into this a little bit more deeply, each one of these stages. But how should women approach these stages?
Well, I think it's individualized and depends on the woman, of course, and their needs. But as OB-GYNs, we start to get involved in those late teens, early 20 years for a number of reasons. Probably most importantly is to give education on safe sex, birth control, and probably most importantly, vaccination for HPV, which is the most common STD.
STD is a sexually transmitted disease. What's the difference between an STD and an STI, sexually transmitted infection?
Just different terminology,
okay.
but just takes in that broad spectrum of bacteria and viruses, basically.
So in 20s and 30s, you're focusing on contraception. What type of birth control options do women have now?
There's quite a few out there. The women that tend to come to see us tend to be certainly more proactive and want something convenient. So we initially have conversations and look at risk factors, but in general, the majority of these younger women are going to be healthy and appropriate for any form of birth control. So we usually divide it into hormonal birth controls versus non-hormonal. The non-hormonal are fairly limited. Usually it's some combination of natural family planning, trying to predict when a woman's fertile, and then maybe using barriers like condoms. For women that maybe use no birth control, there is the morning after pill, which is available. The hormone contraceptives, we have quite a bit of options now. So we tend to ask questions about how long do they need birth control? Do they need something reversible? How convenient do they want to have it? What side effect profile are they looking at? So everyone knows about birth control pills, which have been around a long time, so that's usually a good starting point.
But they're a lot safer now than they were 25, 30
years ago.
They are.
The dosages have come down significantly. They're very safe for the general population in general. In addition to birth control pills now, we have things like the birth control patch, which is worn on the skin and changed weekly. Sure. There's a really neat product that came out of Europe quite a few years ago called NuvaRing. This is a vaginal ring that's just placed in vaginally by the woman once a month. We have an older method called Depo-Provera, which is an injection in the arm every 3 months. We now have a new implantable device. It's a little rod that goes in like an IV under the skin of your arm, lasts for up to 3 years. And then the IUDs have become much more popular again, especially in our Gen Z and millennials. So
technology is just, it's fascinating, isn't it?
It is.
The evolution of it. And then when you talk about prenatal, perinatal care for high-risk pregnancies, that's over what constitutes a high-risk pregnancy?
Well, high-risk pregnancies, hopefully some of the factors can be determined prior to conception. So we do advise women that if they're planning to get pregnant, it would be a good idea to see an obstetrician in advance of conception, look at risk factors and discuss a plan of management, especially in the early pregnancy. One thing we like to talk about before conception now too is to make sure they institute prenatal vitamins or a folic acid supplement that reduces certain birth defect risk. And also to see if they're interested in doing what's called carrier screening. So they can now be screened through blood testing to see if they might carry some of the more common autosomal recessive disorders. Things you may have heard of like cystic fibrosis, Fragile X, spinal muscle atrophy. So we look at a panel that might affect children and offer this to women prior to pregnancy if possible.
And then also what about gestational diabetes? Talk a little bit about that.
Yeah, so once a woman becomes pregnant, most of the risk factors can be determined on how the pregnancy plays out. But Some of the more significant risk factors can be maternal obesity can be a big problem, maternal age can be a problem, especially for 40-year-olds and above. We'll see more problems.
Such as?
Well, you definitely see that population is going to have higher rates of high blood pressure. They're going to have more diabetes. They just in general might tolerate pregnancy less well than the 20-something-year-old. They have a little higher C-section rates and things. So that population can be a little more challenging.
And then talk about, in the 20s and 30s, you also talk with women about heavy periods and also endometriosis. Talk a little bit about that.
Yeah. So that almost might get into a little bit more of that group leading into menopause. So from the 40s to 50s, it is not uncommon to see patients for complaints of heavier periods, maybe more discomfort with periods, less predictable periods. And that population, some of it can just do with hormone balance and changes in their body as they're getting a little bit older. But some of the more common conditions that are benign are things like endometriosis and fibroids, another common thing that might lead to issues like this in their 40s.
And then what other screening tests did you have in your 40s and 50s?
Well, if we talk about screening tests in general, for us, we recommend that like cervical cancer screening or pap smears begin at age 21. The current recommendations are they should be done at least every 3 years from 21 to 30. And then we recommend continuing screening from age 30 to 65. And that screening interval should be 3 to 5 years. And that is now a combination of both the pap smear plus screening for HPV or human papillomavirus. As far as other screening tools like breast cancer screening, that has become a little more controversial for women in their 40s, but as OB-GYNs, we tend to be a little more conservative, so I'm still recommending a baseline mammogram around age 40. I would recommend at least every 2 years from 40 to 50, and then from 50 to 75, I would recommend yearly screening. Okay.
And then talk about the different types of breast cancer screening. I mean, I know that there's digital mammograms and there's this tomosynthesis, and this is for women who have much denser breasts.
Mm-hmm. Yeah, so I think at Scripps Health at least, our radiology department for the most part is 100% digital readings on mammograms now, which is in addition to just the radiologist reading the films, there's also kind of a cross-check with the digital imaging now. Tomosynthesis just means you're doing a standard mammogram but taking many more pieces or pictures through the breast. So for women with dense breast disease, maybe at higher risk for breast disease, this would be a good option for them. In general, women with just dense breasts and otherwise no risk factors, they're a harder group to know what to do with currently. My recommendation is those women might consider bilateral breast ultrasound in conjunction with mammography once a year, and maybe even like a breast specialist to be part of their care.
And then also in your 40s and 50s, obviously there's fertility issues, but talk about also pelvic organ prolapse. What is that?
Yeah, okay. Pelvic organ prolapse typically is more common to happen in women that have had vaginal births. Typically the more births they have, maybe the greater risk. The more difficult the births have been, the more likely, the bigger the baby, okay? There's also some genetic predispositions. So you'll see thinner, fair-skinned women tend to have smaller supporting ligaments to begin with, so they might be at higher risk than a heavier set, dark-skinned person. But in general,
so what happens when you have the prolapse? What does that mean?
So there's kind of three components to the vaginal canal. So we're talking about basically the vaginal canal is dropping or coming down or even sometimes coming out. So you have an anterior compartment, which is kind of the support for the bladder base, a posterior compartment, which is really the rectum, and then there's the uterus and cervix itself in the upper portion of the vagina. So any or all three of those organs can actually be coming down.
And what are the symptoms of that?
It can vary quite a bit. Sometimes we just pick it up on pelvic examination, but patients that come in symptomatic, the most common complaint is that they just feel a heaviness, a fullness. They might literally feel something coming out. It can sometimes interfere with comfort during intercourse.
And then in your 60s and 70s, what are the issues that you deal with?
Again, these are women post-menopause, of course, and maybe many of the issues that gynecologists might deal with have already started to occur in the 50s. So menopausal symptoms like hot flushes, mood changes, vaginal dryness. These are all things that typically come up from the early 50s into the early 60s, and that's the most probably common reason why they come to the gynecologist for care for those things. But we continue to see women, like I said, pelvic examination, pap smear is still reckoned to be done into the mid-60s and older, depending on sexual activity. We also feel we do a good job of screening for cervical or pelvic or gynecologic cancers, so pelvic examination is still important.
And then what about also bone density and dementia and heart issues and cancer?
Yeah. So most of our patients, like I think by the time they get to their mid-50s into their early 60s, my recommendation is they should probably also have an internal medicine specialist be seeing them as part of their annual physical exam. Many women will start to transition to an internist versus an OB-GYN at that age as well. And obviously they get involved in this type of screening as well. We remind them in their early 50s to consider colonoscopy as a baseline screening examination. Bone density studies have also become a little more controversial, but I recommend them now when a woman has either been in menopause for 10 years or longer or by her early 60s, okay? Other than that, it would be women just with maybe risk factors. So if there's a strong family history of osteoporosis, if a woman has to be on chronic steroid use, there are several risk factors that might increase the risk of osteoporosis.
So hold this thought, we're going to come back to this. I know that there's all kinds of attitudes regarding hormone replacement therapy after you've gone through menopause, and I know that there have been news articles about hormone replacement therapy may be increasing risk of cancer. So hold that thought, we'll come back to that in just a couple of minutes. You are a big advocate of minimally invasive gynecologic surgery. Can you explain what that is and what are the advantages of it?
So MIS, or minimally invasive surgery, takes in a big portion of surgical interventions these days, but the most common thing for us, like gynecologists were actually pioneers in minimally invasive surgery back from the 50s. When laparoscopy first came into play, gynecologists were the first people to adopt these things, and we have continued to be the trendsetters, honestly, for minimally invasive disease. So
when you say laparoscopy,
right.
Easy for me to say. What
So
do you
these
mean
are
by that?
surgeries that are done through very small incisions in the abdominal wall. Typically a camera is put in at the belly button, and then there might be several other very small ports to actually put instruments in to work in the pelvis. Things that
So it's not cutting the entire
Right.
abdomen open.
Correct.
So way less invasive.
Way less invasive.
Faster healing.
Faster healing, faster time back to activity, work, lower complication rates, less time in the hospital, and markedly less pain.
And getting back into that bathing suit
You
without
got
a
it.
big scar.
Absolutely.
Talk about infertility treatments. What's available out there?
Yeah. So, I mean, that should, of course, be tailored to the couple, of course, and I treat people different based upon their age group. So I'm certainly going to treat my 20-year-old a little bit different than my 40-year-old. So if a 20-year-old comes in typically without risk factors, most of us recommend that they continue trying for up to a year even before any intervention is done. If I have a 40-year-old who's getting towards the end of reproductive age group, I might take that down to 3 months or 4 months and say, hey, let's think about this earlier. So basic testing typically involves, semen analysis from the spouse, and then some basic fertility testing includes lab function to look at ovarian function, ultrasound to look at the pelvic anatomy, consideration of injecting dye into the uterus to make sure the fallopian tubes are open, and that entails a good part of the basic workup. I'd say probably 80% of the time, just through that simple testing, we can identify something. About half the time it's a male factor, half the time it's on the woman's side. And there are things obvious that we can do at that point. For those 20% that we can't figure it out at that point, those are the people who are usually referred on to a reproductive endocrinologist or a fertility subspecialist. And their main focus these days is to consider like direct intrauterine insemination, or in vitro fertilization, where they harvest eggs and they create embryos in the lab and then put them back into the uterus.
What's the success rate of in vitro fertilization these days?
Depends a lot on your population. So the younger the woman, the healthier the woman, the higher the chance of success. So once you get into the mid 40s or later, success rates have now gone down very significantly. There's a couple simple tests that are usually done early in the cycle to assess ovarian function. So we do a test called follicle stimulating hormone and something called anti-Mullerian hormone testing. It's usually done around day 2, 3, or 4 of a cycle. If those labs are normal, it predicts a very good chance of success with egg stimulation harvesting. If those numbers are not good, a much lower rate of success. So that's why we use our fertility subspecialist to determine what's best for that individual patient or couple.
And what about sterilization? Who gets it and why?
Yeah, I think with all the methods of birth control we talked a little about before, sterilization is becoming less common. But when you look at those couples that know they've completed childbearing, absolutely sure they don't want to ever be pregnant again, sterilization is certainly worth discussing. And in the general population, about half the time males will do it, half the time females will do it. For the men, it's vasectomy. For women, it's some type of tubal blockage. Still most common is a tubal ligation, which is also done through that small laparoscopic type surgery.
And then let's fast forward to menopause. Women are told, oh, you're going to be, soaking yourself all day long, and you won't be able to sleep, and you're going to have all these crazy symptoms. Does that happen for every woman, or is that kind of a myth out there? I mean, how does menopause usually present itself?
I tell my patients it can present from the lucky person who the only thing that changes is their periods stop, to the worst where a woman is just miserable with these hot flushes and other symptoms. The majority of patients are going to be in between those two extremes. So there's a familial predisposition, so you'll see if the patient's mother had a lot of trouble, they're more likely to. And for the patients that start to have symptoms in those years leading up to menopause, if they're starting to have symptoms, they're typically going to have a little bit more severe symptoms.
So there really is a genetic component. So if your mom, went through menopause and it was really horrible for her, chances are how much greater that it's not going to be easy for you as well.
Yeah, whether it's genetic or expectations, I think that is part of it as well. But definitely, I think that comes into play.
And what about osteoporosis? If your mom had osteoporosis, are you more inclined to end up getting osteoporosis?
Yeah, I mean, most women, they take after their moms to some extent, certainly, and there's obviously genetics there. Mm-hmm. So, if your mom is thinner, fair-skinned, and developed osteoporosis, certainly if you have that same body habitus, you have a little more likelihood. But, the preemptive things you could do are healthy lifestyles. So non-smoking, alcohol in moderation, regular exercise, especially weight-bearing, calcium supplementation with vitamin D. And a lot of it can be prevented by doing that.
All right, we referenced this a couple of minutes ago. Let's come back to it. Hormone replacement therapy has been kind of controversial over the years. Why don't you talk about what exactly hormone replacement therapy is and what is the risk for getting cancer from it?
Sure. So hormone replacement therapy is, as it says, a hormone therapy for the average woman that has a uterus in place. The combination is usually of estrogen and progesterone. These are the same types of hormones that are actually in birth control pills, but different in that they're more estrogen dominant. They're meant to replace what is starting to decline in production naturally in the body. Again, my recommendation is that should be very individualized and something you should talk with your doctor about. So, but I do think for women that are symptomatic, women that are really having trouble with hot flushes, as a result, insomnia, fatigue the next day, difficulty getting through their daily work, those are people that are usually very good candidates for it. And if you start hormone therapy in a typical woman who's going to be in her late 40s, early 50s, and otherwise in good health, I think it's a great option for them. And what we try to do is find a program that is the lowest dose that's effective, and then we'll continue it for as long as is necessary. And for the average woman, that will be several years. But by the time they get into their late 50s, 60-ish, often they'll find they no longer have symptoms and can discontinue therapy.
Is there a protection that comes with hormone replacement therapy? Does it protect certain organs in the body?
I think it's controversial. I think it's a symptom reliever for the most part. We think that the downside is that there's a slight increased risk of breast cancer as a result. Older women that might have pre-existing cardiovascular disease that might precipitate a blood clot that can cause heart attack, stroke. But again, for the younger women, it's still a pretty safe option.
Okay. So we talked about this at the beginning. I just want to go back and laundry list it just so that people can remember it. At what age and how often should you start getting screened for things such as, so we'll just go right through the list and you tell me, breast cancer, once again?
Age 40.
Age 40, and then how often should you get tested?
I think every 1 to 2 years in your 40s and 50 to 75 once a year.
And then bone density?
I think, again, with risk factors, you might start at any age, but for the average woman, I'd say around 60.
And how often should you get it tested?
Depends on the initial test and, again, your risk factors, but assuming your bone density is normal, every 3 years at that point.
HPV vaccine?
HPV vaccination, I would highly recommend in early teenage years for both boys and girls, and that's important to get the boys vaccinated as well. The younger women under age 14 can actually get away with just 2 vaccines, 2 injections. The standard course is 3, so the younger woman can save 1 extra sore arm, okay? But I highly recommend it for any woman at any age is sexually active. Most insurers will cover it up until age 27, so you should try to get it done before that age.
And the HPV vaccine protects you from what?
Well, HPV stands for human papillomavirus.
Right.
Again, it's the most common STD out there. HPV can cause cervical disease, including cervical cancer. It can also cause warts of the genital tract. So the current vaccine is Gardasil 9. It's the newest thing on the market, and it has crossover, so it prevents a lot of this disease, or even women exposed to HPV tend to clear it faster after they've been vaccinated.
How often should you get a Pap test?
Pap test should begin at age 21, every 3 years from 21 to 30. From 30 to 65, every 3 to 5 years, depending on your preference. And then 65 and beyond would be individualized based on need, but could be discontinued for many women at that point.
And then a colorectal screening?
So colonoscopy for average risk people still 50 to 55 and good for 10 years. African American women, there's some data saying they might want to take that down to age 45 now.
Any other screening that you should get on an annual basis?
I just
every
think
couple of years?
see your doctor at least every 1 to 2 years. And again, for my patients that get into their 60s and beyond, I usually make sure that they're also seeing an internist in addition to OB-GYN.
So the big takeaway from all of this, doctor, is what? What's the baseline for all of this, I guess?
You know, there's many stages to a woman's life, and as you said, it's a complex organism.
Yes, we are, with pride.
And I think based upon those ages of preconception, times of reproduction, times leading up to menopause, times after menopause, a woman has markedly different needs. And I think be proactive about your health, see your doctor on a regular basis. Don't be afraid to bring up any issue that's important to you. So be open.
No question is unimportant. Every question is
important.
You got it. Dr. Mitchell, thanks so much for
My
being
pleasure
with us.
again.
We appreciate it. If you want more information about women's health, please click on the link or go to scripps.org/videos. If you want more critical information about your health, we take care of you from head to toe. We urge you to please subscribe to the Scripps Health YouTube channel or follow us on social media at Scripps Health. I'm Susan Taylor. Thanks so much for joining us. It's our mission at Scripps to help you heal, enhance, even save your life.